So we'll go ahead and talk about genetics. This picture is from an article we had in Scientific American, and they did this evocative image to show the hidden danger represented by ascending aneurysms for the general population. And I think they did a very good job with that. But genetics can help to mitigate that danger, clinical and molecular genetics. And let's explore that a bit together in the next 10 or 12 minutes. Especially gene-tailored management can decrease the virulence and threat posed by these aneurysms. So the way we became aware that thoracic aortic aneurysm was hereditary was through this one case that I'll describe to you. This was 1999, and we knew about Marfan's disease, but otherwise we didn't know that ascending thoracic aneurysm was inherited. And I was rounding on a patient. It was post-op day 3 after we did a dissection repair on her. She was well. She was on the floor. And I said, ma'am, has anybody else in your family had this problem? And she said, well, doctor, don't you remember 15 years ago you operated on my mother for the same exact issue? Of course, I had no recollection. I doubt you, my colleagues, would have a recollection after 15 years. And that's when I said with my team, has anybody else in your family been affected? And the tears started to flow. She was inconsolable. And finally, she was able to let us know that her 12-year-old daughter had died. She said, they told me it was something with her heart. So we looked up the case, and her 12-year-old little girl was the youngest patient ever to die at Yale University of a type A dissection. So here we had 3 generations in one family. At that time in 1999 and thereabouts, they used to joke that surgeons aren't that smart. But I'll tell you, we do have common sense. And if you hit us on the head with a hammer, we pay attention. And for me, this was like being hit on the head with a hammer. I couldn't figure out why 3 generations would be affected. So our team went to work immediately, and they constructed 100 family trees. And from those 100 family trees, we had these 21 positive pedigrees. This was an immediate finding, 21% rate of familial inheritance. And at the same time, Dr. Milowitz published her paper, and you could take her paper and ours and superimpose them. She found the same 21% incidence of familial transmission. So that was an indication that this could be a hereditary disease. Now, of course, since that time, gene sequencing has been developed and proliferated and gotten cheaper and cheaper. And everybody knows what this means. I don't have to go through this diagram. But it was in the year 2000 that Craig Ventnor had his genome mapped. He was the president of Celera Genomics, and it cost millions and millions of dollars and took years for that to be done. And now it's about $250, and it can be returned within weeks. So this is fascinating, really. The human genome contains 3.2 billion letters or bases, adenine, guanine, cytosine, and thymine. But thoracic aortic aneurysm is caused by a change in just one letter. That's absolutely astounding. It's like on a large beach, like one single grain of sand determined the fate of the entire beach. It's just astounding that this is a one genetic letter, one base disease. Now, of course, we knew about size, that was important, and we'll talk about this a little bit more in the next talk that you've assigned me. But it's definitely not the whole story. And we began right away with routine genetic testing, and we got a running start with this. And all of the patterns of thoracic aortic aneurysm, we used to put in one bucket because we didn't know any genetic separation of different diseases. So everything went in one bucket. But with the 20 years of progression of sequencing, we now know that there are 67 individual genes that have been associated with development of thoracic aortic aneurysm. So I've indicated them for you here with colors, and the colors define the strength of the relationship to aneurysm. Red is definitive, yellow is strong, and green is moderate, and blue is limited. And the uncolored ones have been associated, but it's not a strong association. So among the ones that are fairly well substantiated, we've got 17, and those are the ones I've indicated for you in color. Now, this allows us no longer to put every ascending aneurysm patient into one bucket, but rather we have a different bucket for every single gene, every mutation. And that way we can provide gene-specific care. This is a dramatic advancement in scientific treatment of ascending aortic aneurysms. Because we got an early start, I can say that Dr. Zaganshin, whom many of you may know from my team, he sequenced 753 of my own explanted aortas. And this is what we found. We found that the fibrillin-1 and Notch gene, MHY11 and fibrillin-2 were the most common genes that we saw, but many, many dozens of individual genetic variants were found. Now, very, very, very important. Again, inherited thoracic aortic aneurysm is not only a single letter disease, but a dominant disease. You can forget about the two recessives. They're very rare. So that means that not only is it only one genetic letter, but only one parent has to have it for it to be transmissible. Really an astounding genetic determination of this disease that we battle every day. Why is this important? Well, genes like ACTA2 and MYLK can dissect very early before there's any significant amount of aortic enlargement. So we can treat patients with those variants in their specific bucket with care directed to that gene in particular. These are slides from Dr. Milowitz, and you can see that for the ACTA2 variant on the right, there's this horrible, horrible pattern of occurrence of the first dissections at the age of 10 to 12. It's just a horrible disease in those children. And this shows you how important these genetic identifications can be for patient care. Now, about every 2 years, we publish this timeline. I call it a timeline, but it's really a size line. But we aggregate all the papers that have been written about the size at which these different genes produce aortic dissection, and we revise this timeline to give the practicing surgeon a quick and dirty guide. You look up the gene that you found on this timeline, and it gives you an idea when they should be operated. We sequence everybody who walks through the door. And now we're able to correlate not only size at the time of dissection, but age, as you see in this scatter plot here. So we're really zeroing in on the clinical behavior of each of these genetic variants. Now, there's a problem here, though. When we send the patient's sputum or blood for analysis, the geneticist and ourselves, the surgeons, we have a completely different viewpoint. The geneticist wants to be 100% scientifically accurate. He doesn't want to assign the label disease-causing without meeting extreme criteria, which we will review in a minute. But we can't wait years and we can't wait generations because we have to keep the patient alive. So our viewpoints are different. And I'd like to show you something that we're doing that may ameliorate this disconnect between specialties. I don't mean any disrespect for our geneticists. I have the highest respect and I learn from them every single day, but it's a different viewpoint and different priorities. So those of you who are sending specimens for analysis, I'm sure you find that your most common report is variant of uncertain significance. This is most commonly what they report to us because they can't absolutely associate that variant with the disease. So let's look at what that means. Well, these are the 5 categories that the Genetic Society allows them to use: benign, likely benign, uncertain, likely pathogenic, or pathogenic. But this can be a quandary for the families, not really to be able to understand the significance of their genetic report. Now, these are some of the factors that the geneticist will use in assigning a category of pathogenicity. First of all is rarity in the general population. If it's not rare, it's not the cause of the disease, because aneurysm is fairly rare. And so if it's a common variant, that can't be it, because one single variant would account for all the disease seen by mankind. Another factor is the impact on the reading of the genome. Does it stop the reading of the gene completely? Does it not interfere with the reading of the gene at all? Another factor is the preservation through phylogeny. A gene that is completely preserved through phylogeny is very likely to be important. And finally, there's segregation of genotype and phenotype. And let's look at these criteria a little more closely. So rarity in the general population, our genetic team doesn't even consider it as potentially disease-causing unless it's seen in less than 1 in 10,000 human beings. Otherwise, it would just be too frequent. The impact on the reading of the gene, the base pairs determine the amino acid that's produced, and then that determines the protein that's produced. This is a complicated chart, and it took me a while to read it. But what it means is that there can be sharing of the first and second letters in a triad. A triad constitutes a letter, and it can still produce the same protein. So a geneticist can tell scientifically from the exact gene sequence how likely that sequence is to cause a major abnormality in the reading of the remainder of the gene beyond the site of the variant. And here I've shown you preservation and phylogeny going from humans down to a very less complex organisms. The most important genes are preserved through phylogeny, as you see in these columns that have the same letter all the way down through possums and zebrafish and chickens and so on. If it's maintained through phylogeny, it's likely very important. And finally, segregation of genotype with phenotype. That is, does everybody in a family who has that gene develop the disease? But that takes generations to determine. So that's not going to help us in the clinical care of a specific patient. Yes, we have some families like this one where we know for generations what's happened, but it's very unlikely to have that much information. And this type of pedigree analysis, it will take generations. And if a generation is 20 years, that has no bearing on the treatment of our patient, that type of information. So some type of more rapid solution to this problem of variants of unknown significance is needed pretty urgently. Let me tell you an avenue that we're exploring. So we've started a zebrafish program in which we evaluate genetic variants. By CRISPR, we install the variant in a zebrafish embryo, and then we look for its consequences. These are pretty little fish that they replicate very rapidly. And the way the geneticists explained this to me is they have a tank with a divider down the middle. And all the males are on one side and all the females on the other side. And when they pull the divider out, within 3 minutes, all the females are pregnant. That's how rapidly these zebrafish procreate. Now you can see some of our early results here, and I hope you can see my pointer, but you can see uninjected fish, how beautiful their skeleton is. But look at these abnormalities, these severe abnormalities that we see in the skeleton with some of these genes. And we're starting to see vascular abnormalities in the dorsal aorta as well. And we also see brain hemorrhages and aortic hemorrhages. So it looks like we have a phenotype in the zebrafish for human thoracic aortic disease. We recently published our findings in the journal Genes, and we're hopeful that this rapid, inexpensive animal model may provide some relief of this conundrum of the variant of unknown significance. It may bring the surgeon and the geneticist closer together and help to relieve the patient anxiety that these equivocal genetic reports produce. I'd like to go on now to some clues that we can use in clinical practice that are based on clinical genetics. First, and very important, we found that once one family member has the gene, the likelihood of another family member who carries an aneurysm, clinically has an aneurysm, the likelihood of developing an aneurysm, a dissection, is raised by threefold. So if I have a family member sitting in my office and his family member has dissected, I'll extirpate the aorta almost regardless of size. And then I'd like to talk to you about KIF6. Now, KIF6 is an essential gene for microtubular motors that transport vesicles and other intracellular structures towards the nucleus. Why do I care about this? Well, what we found and just recently published is that if a patient has this ARG variant, this ARG variant, either homozygous, heterozygous, it doesn't matter, it doubles the likelihood that that patient will suffer an aortic dissection. Now you may say, John, you're picking this one gene, how can I get that tested? Well, this was the gene that was used for the last 20 years to test statin responsiveness in coronary artery disease. You can order this through Quest. That's why I'm excited about it. To know that our patient has a double likelihood of dissecting is very, very important, and I think it can influence our decisions. This thumb palm sign, we all know about this, having the thumb extend beyond the flat palm and achieve that right angle. Well, we've looked at this, and one of our students actually tested hundreds and hundreds of patients for this test. It's not sensitive. Of course, you don't have to have this to have an aneurysm. But if a patient has this test, that patient has an aneurysm with a 96.7% certainty. So there's a clinical clue that we can use in daily practice. And then we're trying to spread the word among internists and general practitioners that when a patient has any of these conditions that you see here, they should think about thoracic aortic aneurysm, which we now know is correlated with intracranial aneurysm, positive family history, renal cyst, temporal arteritis, abdominal aortic aneurysm, bovine arch, and so on. So these are clues that can help us prevent the aneurysm from going undetected. And let's face it, once we know a patient has an aneurysm, we won't let him die. We know when to operate. We know how to operate. The issue is identifying the asymptomatic patient in the general population. I'd like to finish this particular talk by covering what I feel is a real genetic silver lining from having an aneurysm gene. Now, you might say everything is negative. Could there be anything positive? We've got pretty strong evidence now that there is a silver lining. And when we operate on patients with pure ascending disease, their femoral arteries are fine. They're like a teenager's. And we know that the ascending aorta, in complete contradistinction to the descending and abdominal, is usually smooth-walled, non-calcified, and non-thrombus containing. So we looked at this. The first thing we examined was the total body calcium score. With all the traditional risk factors, dyslipidemia, smoking, hypertension, male gender, you have a higher calcification score. But if you have an ascending aortic aneurysm or an ascending dissection, you have a very low calcium score, total body calcium score. And we published that, and then people said, well, John, that's a very late finding of arteriosclerosis. Well, the best indicator of early arteriosclerosis that medical science has is intimomedial thickness of the carotid artery. And we looked at that, and please note how these two graphs of early and late indicators look identical. Again, with all the traditional risk factors, hyperlipidemia, diabetes, advanced age, hypertension, the intimomedial thickness is high. But with an ascending aneurysm, the intimomedial thickness is even lower than it is for the average normal patient. What else do we see? Well, the incidence of coronary artery disease and myocardial infarction is pretty darn low. Has anybody seen a Marfan patient with coronary artery disease or myocardial infarction? I've never gotten a positive answer to that question. Maybe somebody in the audience will have the first positive I've ever heard. And look at this, when we analyzed risk factors for myocardial infarction, this is the risk in patients with thoracic aortic aneurysm. It's essentially zero. And then very recently, we published this information. If you have an ascending aortic aneurysm, your LDL is very low. So now this is starting to fall into a pattern. Not only do we see less clinical coronary disease, but we find that patients with an aneurysm have a very low LDL. So somehow those aneurysm genes are conferring this protection from arteriosclerosis. So the gene, although proaneurysmal, is in some way anti-atherogenic. So there is real protection from atherosclerosis. Thank you for your attention for this lecture. And I'll stop here and be happy to handle any questions or comments.
While you're thinking of questions, I've got one. It's often said that, and I think you mentioned in your talk earlier, that 30% of genetic screening comes up positive for patients with aneurysms. Am I correct?
That's exactly what we find. 1 out of 3 comes up positive, almost always as a VUS, a variant of unknown significance.
Is there
I think that percentage will increase, George, because new genes are found, 1 or 2 every 1 to 2 years.